Welcome back to the deep dive, everyone. This is where we take those really complex topics, unpack them, and pull out the key insights you need to be genuinely informed. Today, we're diving deep into a subject that's both vital and honestly pretty intimidating for many: cancer chemotherapy. It touches countless lives and, well, it's constantly changing. Okay, let's unpack this right away. The sheer scale of this challenge is huge. Just think, in 2023, projections were around 1.9 million new cancer cases diagnosed in the USA, and the deaths, nearly 609,000 projected. It's the second leading cause of death in the US. That means roughly 1 in every 4 deaths is due to cancer. It's incredibly personal for so many people.
And if you really want to master this information, get that deep understanding, like the elite professionals in this field, you can't just look at chemotherapy as a list of drugs. It's really a highly sophisticated, multifaceted scientific effort. It's all built on a really profound grasp of biology. So our goal today is to give you that foundational knowledge, the why behind the what, so you can not only understand current treatments, but also, see where future breakthroughs might come from in this really dynamic field. And that foundation really starts with understanding cancer itself, its inherent complexity. At its core, you see, cancer is a disease marked by fundamental defects. Defects in the normal control mechanisms, the ones that govern how our cells survive, how they proliferate, and how they differentiate into specialized cells. Just think about that for a second. It's a breakdown in the very programming that keeps our bodies running smoothly, in balance. These neoplastic cells, the cancer cells, they aren't just normal cells gone a bit haywire. They have unique features. For example, they might express antigens on their surface that you normally only see during fetal development. Or they might show other signs of being, well, immature. And crucially, they often have major chromosomal abnormalities. Things like translocations, where bits of chromosomes break off and reattach elsewhere, gene fusions, amplified gene sequences. It's complex. We're not fighting a simple infection here. It's a fundamental subversion of our own biological processes.
That's a really powerful way to phrase it, a subversion of our own biology. So if cancer is this deep-seated breakdown, how do these abnormal cells get so dangerous, so invasive? How do they spread? And what about this term we hear, tumor stem cells? What role do they play?
That's a critical point, yeah. Gets right to the heart of why cancer is so persistent and why it spreads. Within any tumor, you find this small but incredibly significant subpopulation of cells. These are the tumor stem cells. They're not just any cancer cells. You could almost think of them as the masterminds behind the tumor's resilience. They have this remarkable ability to just keep proliferating, cycle after cycle. They can continuously divide, expanding the tumor. But maybe even more insidious is their ability to migrate, to travel to distant sites in the body. This is what kicks off metastasis. They can actually colonize different organs, setting up shop, forming entirely new tumors far from the original one. And these tumor stem cells, they also have what we call clonogenic capability. That means just one of these cells can potentially start a whole new colony of cancer cells. A key feature, reflecting their basic instability, is widespread chromosome abnormalities. This directly translates to profound genetic instability. And this instability isn't just, random chaos, it's the engine. It drives this progressive selection of subclones, sort of specialized versions of the cancer cell, that get better and better at surviving within the host environment. They adapt. And here's a really crucial part. This very genetic instability is precisely why cancer cells can become resistant to therapies. Radiotherapy, cytotoxic chemotherapy, targeted drugs, even the latest immunotherapies. It's like this ongoing arms race inside the body, where the cancer keeps evolving to evade our defenses.
So understanding those cellular defects, the role of these master tumor stem cells, what does that actually mean for the patient? It's obviously more than just a lump. It sounds like a cascade of biological problems causing very real symptoms.
Absolutely. Those deep cellular problems translate directly into invasive processes, letting the disease spread. They cause metabolic abnormalities that can really sap a person's energy and health. They lead to all those tumor-related symptoms that impact quality of life. And ultimately, yes, unless the cancer is eradicated by treatment, it can lead to death. And while we're focused on these internal mechanisms, it's just as vital to understand the external factors, the environment, things like sex, age, race, genetic predisposition. They all play a role in the incidence and behavior of specific cancers. But often, environmental exposure is probably the single most important factor. Though it's always this complex interplay, right, between our underlying genetics and the environmental triggers we encounter.
Can you give some specific examples of those environmental triggers?
Sure, ionizing radiation is a big one. It's a known risk factor for acute leukemias, thyroid cancer, breast cancer, lung cancer, and certain skin cancers. Then you have chemical carcinogens. The ones in tobacco smoke are obviously major players, linked strongly to lung and bladder cancer. But there are others too. industrial chemicals like aerosol dyes, aflatoxins from mold, asbestos, benzene, radon, all linked to various cancers. And we can't forget viruses. Several are definitively linked to human cancers. Chronic hepatitis B and C infections, for instance, are a major cause of hepatocellular cancer, liver cancer. HIV increases the risk for certain lymphomas and anal cancer. HPV, the human papillomavirus, is strongly tied to cervical cancer, plus anal, penile, and some head and neck cancers. That's why the HPV vaccine is so important. Even Epstein-Barr virus, or AVV, is linked to things like nasopharyngeal cancer and Burkitt lymphoma. But it's important to remember, even with these virus-induced cancers, development often depends on other host and environmental factors. It's usually not just the virus alone.
It's amazing and a bit scary how many angles of attack there are, both from within and without. Which brings us right back to the genetics inside our own cells. You mentioned them before, oncogenes and tumor suppressor genes. Can you break this down a bit more? It sounds like they're fundamental players, maybe on opposing teams.
They absolutely are fundamental, and yes, they are definitely on opposing teams. It's a great way to think about it. Imagine cell growth like driving a car. Oncogenes are basically the accelerator pedal. In their normal, healthy state, these genes code for things like growth factors and their receptors, the signals that tell a cell, okay, time to grow and divide. But in cancer cells, these oncogenes can get messed up. They might undergo amplification, meaning you get way too many copies of the gene, or they might get mutated. Either way, it often leads to constitutive overexpression. The accelerator gets stuck down, constantly pushing for uncontrolled growth. A good example is the BCL2 family of genes. These are pro-survival genes. They directly block apoptosis, which is programmed cell death, the cell's natural self-destruct mechanism for damaged cells. So by blocking apoptosis, BCL2 helps tumor cells survive when they really shouldn't.
Okay, so oncogenes are the stuck accelerator. What about the tumor suppressor genes then?
Right, if oncogenes are the accelerator, tumor suppressor genes are definitely the brakes. Their job is to produce proteins that prevent cancer. They control cell growth, division, DNA repair. They keep things in check. But if these genes get deleted or mutated, their protein products are either missing or just don't work properly. The brakes fail. And when the brakes fail, you get the neoplastic phenotype of the cancer cell characteristics. The most famous, the best established tumor suppressor is probably the p53 gene. The normal p53 protein is absolutely critical for suppressing tumors. It's involved in stopping the cell cycle, initiating DNA repair, and even triggering apoptosis if the damage is too severe. Here's a really critical statistic. p53 is mutated in up to 50% of all human solid tumors. Think liver, breast, colon, lung. It's incredibly common. And this loss of p53 function isn't just about uncontrolled growth. It also directly leads to resistance to radiation therapy and a whole range of chemotherapy drugs. So losing the brakes not only lets the car speed out of control, it makes it incredibly hard to stop it once it's going.
That accelerator and brake analogy really makes it clear. So understanding this complex enemy, the broken genes, the tumor stem cells, the environmental factors, that really sets the stage for discussing how we fight back. Let's shift gears now from understanding the enemy to the strategies for fighting it. Here's where it gets really interesting, exploring the different ways cancer is actually treated.
Right. When we look at the overall landscape of cancer treatment, it's usually a multi-pronged attack, sophisticated strategy. About a third of patients, roughly, are diagnosed when the tumor is still localized. In those cases, local treatments like surgery or radiation therapy alone can often achieve a cure. That's the ideal scenario. However, for the majority, unfortunately, early micrometastasis is common. Tiny clusters of cancer cells have already spread, even if we can't see them yet. And that signals the need for a systemic approach, something that travels throughout the body to hit those hidden invaders. That's where chemotherapy comes in.
So systemic therapy is often needed even if the main tumor seems localized.
Often, yes, especially if it's considered higher risk. And in cases of locally advanced disease where the tumor is larger or involves nearby structures, we often use chemotherapy combined with radiotherapy. The goal there might be to shrink the tumor first, making surgery easier, safer, and more likely to get everything out. This combined modality approach has definitely improved outcomes. Overall, with everything we have now, about 50% of patients diagnosed with cancer can be cured. That's huge progress. But, and this is important, chemotherapy alone cures less than 10% of patients when the cancer is diagnosed at an advanced metastatic stage. It highlights why we need combination strategies and more targeted approaches.
That 10% figure really drives home the challenge. Okay, so when we talk about chemotherapy specifically, how is it actually deployed during a patient's treatment journey? Can you outline the main clinical settings?
Absolutely. Chemotherapy is generally used in three distinct clinical settings, each with specific goals. First, there's primary induction treatment. This is when chemo is the main initial treatment, usually for advanced cancer where there aren't other good local options or the disease is already widespread, metastatic. The primary goals here are usually palliative in nature: relieve symptoms caused by the tumor, improve the patient's quality of life, and hopefully prolong the time until the tumor starts growing again. And studies do show that chemotherapy provides a survival benefit compared to just supportive care in these advanced settings, which is why we often started early. But to be realistic, chemotherapy is curative in only a very small subset of patients with advanced disease. In adults, we're talking about things like Hodgkin and non-Hodgkin lymphoma, acute myelogenous leukemia, AML, germ cell cancers. In kids, maybe acute lymphoblastic leukemia, ALL, Burkitt lymphoma, Wilms tumor.
Okay, so primary induction is mainly for advanced disease. What's the second setting?
The second is neoadjuvant treatment. Here, chemo is given before the main local treatment, like surgery, even when that local treatment is an option. The idea is to shrink the primary tumor first. This can make surgery less expensive, easier to perform, and more effective. A big potential benefit is sparing of vital normal organs. Think about rectal cancer or laryngeal cancer. Shrinking the tumor beforehand might allow surgery that avoids a permanent colostomy or removal of the voice box. That's huge for quality of life. This approach is often used in cancers like anal, bladder, breast, esophageal, laryngeal, some lung cancers, rectal cancer, often combined with radiation therapy for the best effect. And typically after the surgery, the patient will get additional or adjuvant chemotherapy for maybe 3-4 months.
Got it. And the third setting, you mentioned it's one of the most important roles.
Yes, adjuvant treatment. This is probably one of the most significant roles for chemotherapy. It's given after the main local treatment, like surgery, has removed all visible signs of the tumor. The goal here is crucial: to wipe out any micrometastatic disease, those invisible cancer cells that might have already escaped and could cause a recurrence later. So adjuvant therapy aims to reduce the chance of the cancer coming back, both locally and systemically, and ultimately improve overall survival. Regimens that work well against advanced disease can potentially be curative in this adjuvant setting if given at the right dose and schedule. And we have solid proof it works. Adjuvant chemo prolongs both disease-free survival and overall survival in major cancers like breast, colon, gastric, and non-small cell lung cancer. It's worth noting, adjuvant therapy isn't always traditional chemo. For high-risk melanoma, immune checkpoint inhibitors are used. For hormone-sensitive breast cancer, anti-hormonal drugs like tamoxifen or aromatase inhibitors are key, often given for 5 years or more. Because they're cytostatic, they stop growth rather than kill directly.
So we have these broad strategies: primary, neoadjuvant, adjuvant. But let's get down to the nitty-gritty. How does chemotherapy actually kill cancer cells? What's the underlying science? Okay, let's unpack this. Maybe starting with some of the historical models, like that Marine L1210 leukemia model you mentioned. How does understanding cell growth guide drug design?
Exactly. Understanding the kinetics of cell growth is fundamental. Those early principles really came from studying models like the Marine L1210 leukemia. It was a useful model because it grew very fast. Almost 100% of the cells were actively dividing what we call a high growth fraction. This made it predictable. And from this model, we got the concept of log cell kill kinetics. The idea is that a given dose of a drug kills a constant fraction or percentage of the cancer cells present, not a fixed number. So a 3-log kill reduces 10 billion cells to 10 million. But it also reduces 100,000 cells down to just 100. It's proportional. This led to the cardinal rule of chemotherapy: the fewer cancer cells you start with, the higher the chance of cure. An inverse relationship between cell number and curability. This holds up pretty well for fast-growing blood cancers like leukemias and lymphomas.
That seems straightforward enough for those fast-growing cancers, but you hinted earlier that human solid tumors might behave differently. Does that log kill rule apply across the board?
That's a really important distinction. And no, it doesn't apply quite so neatly to most human solid tumors. Mathematical modeling suggests that most solid tumors follow what's called a Gompertzian growth model. It's not simple exponential growth. The key difference is that in Gompertzian growth, the growth fraction of the percentage of cells actively dividing actually decreases as the tumor gets bigger. It slows down over time, maybe due to limits in blood supply or nutrients. The growth fraction actually peaks when the tumor is about a third of its maximum possible size. Then it starts to drop off. So what does this mean for chemotherapy? It means the response really depends on where the tumor is on that growth curve. A large advanced tumor might have billions of cells, but a smaller fraction of them are actively dividing compared to a smaller, earlier tumor. This is one reason why chemo often seems less effective against very large advanced tumors. Fewer cells are in the vulnerable dividing state at any given time. It complicates the simple log-kill idea.
That makes sense. It's not just about hitting the cells, but hitting them when they're dividing. So how does this knowledge of the cell cycle phases feed into how drugs are categorized and used? Can you walk us through the cycle briefly?
Definitely. The cell cycle is the sequence of events a cell goes through to divide. We break it down into phases. Geophase. This is the resting phase. Cells aren't actively preparing to divide, but they're alive and functioning and can re-enter the cycle. A lot of normal cells, and unfortunately some cancer cells and larger tumors, hang out in G0, G1 phase. Cell growth happens here. The cell makes proteins and components needed for the next step. S phase. This is synthesis. The cell replicates its entire DNA genome. Very crucial, very active phase. G2 phase. More growth in preparation for the final division stage, making sure everything is ready for mitosis. M phase, mitosis. The actual physical process of cell division where one cell splits into two daughter cells.
Okay, G0, G1, S, G2, M. How do the drugs fit in?
We broadly categorize them based on this cycle. Cell cycle-specific, CCS drugs, work mainly on cells that are actively moving through these phases, G1, S, G2, M. They target specific processes within those phases. For example, antimetabolites often hit the S phase by messing with DNA synthesis. Taxanes and vinca alkaloids target the M phase by disrupting the mitotic spindle needed for division. These CCS drugs are generally most effective against cancers with a high growth fraction, lots of cells dividing. Then you have cell cycle nonspecific, CCNS drugs. These agents can damage or kill cells, whether they're actively cycling or just resting in G0. Alkylating agents and platinum drugs fall into this category. Now, while they can kill resting cells, cycling cells are usually still more sensitive to them. Understanding this distinction, CCS versus CCNS, is really key for designing effective combination chemotherapy schedules, trying to hit cells in all different states.
Right, hitting cells in different states. Which leads perfectly into combination therapy. Given the complexity of Gompruzina growth, resting cells, active cells, it seems logical that using multiple drugs would be better. But why exactly is combination chemo so much more effective? Is it just brute force?
It's definitely more strategic than just brute force. And you're right, with very few exceptions, maybe choriocarcinoma, Burkitt lymphoma, single drugs rarely cure advanced cancer. The real era of effective combination chemo started when we had active drugs from different classes available, first in blood cancers, then adapted for solid tumors. So why combine? Several key reasons. First, maximal cell kill. You can push each drug closer to its maximally tolerated dose to kill as many cells as possible, assuming their major toxicities don't overlap too much. Second, broader range of interaction. Tumors are heterogeneous, right? Different cells within the same tumor can have different vulnerabilities. Using multiple drugs increases the chance you'll hit all the different subclones present.
Okay, hitting more cells and different types of cells. What else?
Third, and this is absolutely crucial, it helps prevent or slow down the development of drug resistance. It's much harder for a cancer cell population to simultaneously develop resistance mechanisms to multiple drugs acting in different ways than it is to develop resistance to just one. We see the exact same principle in treating chronic infections like HIV or tuberculosis. Combination therapy is essential to overcome resistance. So when oncologists design these combinations, they follow specific principles. 1. Efficacy. Only use drugs already known to be active against that specific cancer when used alone. 2. Toxicity. Try to pick drugs with non-overlapping toxicities. This allows for higher doses of each drug, maximizing dose intensity. 3. Optimum scheduling. Use each drug at its best dose and schedule, with consistent intervals just long enough for normal tissues like bone marrow to recover. 4. Mechanism of interaction. Understand how the drugs work together biochemically. You can't just randomly leave one out without potentially allowing your resistant clone to thrive. 5. Avoid arbitrary dose changes. Don't just lower the dose of an effective drug to squeeze in a less effective one. You might drop the key drug below its effective threshold and lose the chance for cure.
That's a really clear framework for why combinations work. You mentioned dose intensity again. So what does this all mean for the listener? It's not just about getting more chemo, but the timing and concentration are critical, right?
Absolutely critical. Dose intensity, basically how much drug is given over a specific period of time, is often a primary limiting factor in achieving a cure with chemotherapy or radiation. Think about a dose-response curve. There's usually a threshold, then a steep part where more dose gives much more effect than a plateau. Therapeutic success depends on that steep part hitting the tumor harder than it hits normal tissues.
Now, the critical insight from experimental models is that this dose-response curve for cure is often very steep. If you reduce the dose, even by a seemingly small amount, you might fall off that steep part and lose the ability to cure the tumor, even if you still see some tumor shrinkage initially.
So a doctor might see the tumor shrinking even with a lower dose, but the chance of actual cure could be gone.
Exactly. Clinicians might see continued complete remissions on scans, with doses reduced by, say, 20%. But microscopically, residual resistant cells might be left behind, setting the stage for relapse later. This is why arbitrarily reducing doses or stretching out the time between cycles, often done to manage immediate side effects, is actually a major cause of treatment failure, especially for potentially curable, drug-sensitive cancers. It's a really tough balance. We know that a higher dose intensity correlates with better outcomes in many cancers: ovarian, breast, lung, colon, lymphomas. So how do we achieve dose-intense delivery? Three main ways. 1. Dose escalation, simply using higher doses of the drugs if tolerated. 2. Reduced interval, giving the treatment cycles closer together, sometimes called dose-dense therapy. 3. Sequential scheduling, carefully timing single agents or combinations one after another to maximize impact. These strategies are used widely and have definitely improved outcomes.
Okay, so dose intensity is key. But that brings us squarely to the biggest roadblock: drug resistance. We touched on how genetic instability can cause it from the start, but how does resistance develop during treatment? Let's unpack this. What are the mechanisms?
Drug resistance is, without a doubt, a fundamental challenge. It's why treatments that initially work incredibly well can eventually stop working. We generally talk about two main types. First is primary resistance, or inherent resistance. This means the cancer cells are already resistant to a drug before the patient ever receives it. This often stems from that inherent genomic instability we discussed. Remember the p53 mutations. Loss of p53 function makes cells resistant to a wide range of drugs and radiation right off the bat. Another example involves defects in DNA mismatch repair enzymes, common in some colorectal cancers. These defects confer resistance to several different types of chemo drugs, so the resistance is baked in from the start.
And the second type, resistance that develops later.
Exactly. That's acquired resistance. This develops in response to being exposed to a particular anti-cancer drug. Sometimes this can be very specific. A mutation might arise that affects only the target of that one drug or how it's transported into the cell. But a much bigger problem is the multi-drug resistant phenotype. This often involves the increased expression of a gene called MDR1. MDR1 produces a protein called P-glycoprotein, which sits on the cell surface and acts like a pump. It actively pumps a wide variety of structurally different chemotherapy drugs right back out of the cancer cell. This leads to enhanced drug efflux and reduced intracellular accumulation. So the drugs can't build up inside the cell to do their job. And because this pump works on many different drugs, anthracyclines, vinca alkaloids, taxanes, camptothecins, resistance to one drug mediated by P-glycoprotein can suddenly make the cancer resistant to a whole host of others. It's a major hurdle.
That P-glycoprotein pump sounds like a major villain in this story. It really underscores that constant arms race. Understanding these mechanisms is clearly vital for developing the next generation of treatments. All right, let's shift focus now to the actual arsenal, the specific types of drugs oncologists use. There's so many. Can we start categorizing them and understanding how the main classes work? Maybe begin with the older foundational classes?
Sounds good. Let's start with a major foundational class: the alkylating agents. These were among the first effective chemotherapy drugs developed. Think of them as reactive chemicals. They work by transferring alkyl groups, basically sticky chemical tags, onto cellular molecules. Their most critical target is DNA. They can damage DNA in several ways, but a key mechanism is cross-linking. They can form links either within a single DNA strand or, more damagingly, between the two strands of the DNA helix. This prevents the DNA from unwinding, replicating, or being transcribed properly. While they can affect cells at any point in the cycle, making them technically CCNS, they tend to be most damaging to cells that are actively replicating their DNA. Cyclophosphamide is a very common example. It's actually a prodrug, meaning it's inactive when administered and has to be activated by enzymes in the liver. A major downside of alkylating agents is their toxicity to rapidly dividing normal tissues, particularly the bone marrow, leading to myelosuppression, low blood counts, and the GI tract. They can also cause nausea and vomiting. And critically, because they directly damage DNA, they are themselves carcinogenic and can increase the risk of developing secondary cancers, like acute myelogenous leukemia, AML, years later.
Directly damaging DNA. That explains the secondary cancer risk. Okay, what's another major class?
Closely related in mechanism are the platinum analogs. This group includes cisplatin, carboplatin, and oxaliplatin. Like alkylating agents, they exert their cytotoxic effects by binding to DNA and forming cross-links, primarily intrastrand links, which inhibit DNA synthesis and function. They're also considered CCNS drugs. Cisplatin was a landmark drug. It has broad activity, especially in testicular, ovarian, bladder, and lung cancers. Cisplatin-based therapy actually cured metastatic testicular cancer, which was incredible. However, it's notorious for causing significant kidney toxicity, nerve damage, neuropathy, and severe nausea vomiting. Carboplatin was developed as a second-generation analog to be less toxic. Its mechanism is the same, but it causes much less kidney damage and nausea. Its main dose-limiting toxicity is myelosuppression. Because it's easier to administer, doesn't require the intense hydration needed with cisplatin, it often replaces cisplatin in combination regimens. Oxaliplatin is the third key platinum. Its mechanism is similar, but crucially, it seems to form bulkier DNA adducts that are harder for some repair mechanisms to fix. This means tumors that have become resistant to cisplatin or carboplatin due to certain repair defects might still be sensitive to oxaliplatin. This is key to its major role in treating colorectal cancer as part of the FO-FOX regimen. Its main toxicity is a characteristic neurotoxicity, often triggered or worsened by cold.
Interesting how resistance patterns differ even within the platinum class. Okay, moving on from drugs that directly damage DNA, what about the antimetabolites? You mentioned that they interfere with building blocks.
It's exactly. Antimetabolites are generally designed to mimic natural molecules involved in the synthesis of DNA and RNA, but they're flawed mimics. They get incorporated into metabolic pathways but then block them. They are typically cell cycle specific, CCS, primarily acting during the S phase when DNA is being synthesized. We can break them down further. First, the antifolates. Folic acid is essential for making DNA bases, purines and pyrimidines. Methotrexate, MTX, is the classic antifolate. It blocks an enzyme called dihydrofolate reductase, DHFR, which is critical for activating folic acid. By blocking DHFR, MTX shuts down the synthesis of DNA precursors, starving the cell of building blocks. An interesting aspect of MTX is that its effects can be reversed by giving leucovorin, a form of folic acid, afterwards. This leucovorin rescue allows normal cells to recover while cancer cells, which might trap MTX more effectively, are killed. This allows for the use of very high doses of MTX. Pemetrexed is another important antifolate, used mainly in lung cancer and mesothelioma. It inhibits multiple enzymes, including cementolate synthase, TSA. A key practical point is that giving patients folic acid and vitamin B12 supplements significantly reduces Pemetrex's toxicity without compromising its effectiveness.
That vitamin supplementation trick is fascinating. What about other antimetabolites?
Next are the fluoropyrimidines. The main drug here is 5-fluorosil, 5-FU. It's an inactive prodrug that gets converted inside cells into several active metabolites. These active forms work in multiple ways. One metabolite inhibits thymidylate synthase, TS, blocking thymine production needed for DNA, thymineless death. Others get incorporated into RNA, messing up protein synthesis, and into DNA itself, causing damage. So it hits both DNA and RNA pathways, primarily during the S phase. 5-FU has a very short half-life and is usually given intravenously, often as continuous infusion. A critical clinical issue is DPD deficiency. Dihydropyrimidine dehydrogenase DPD is the main enzyme that breaks down 5-FU. About 5% of people have a partial or complete deficiency in this enzyme. If they get standard doses of 5-FU, they can experience severe, potentially life-threatening toxicity, myelosuppression, severe diarrhea-mucositis, neurotoxicity. Testing for DPD deficiency isn't routine yet, but monitoring drug levels can help manage dosing. Capecitabine is an oral prodrug of 5-FU. It's designed to be converted to 5-FU, preferentially within tumor tissue, potentially increasing effectiveness and reducing systemic toxicity, although it can cause significant diarrhea and hand-foot syndrome.
That DPD deficiency sounds like something crucial for patients to be aware of. Okay, what other antimetabolite groups are there?
We also have the deoxycytidine analogs. Cytarabine, Ara-C, is a key example. It's an S-phase-specific drug that gets converted to Ara-CTP, which inhibits DNA polymerase, the enzyme that builds DNA strands, and also gets incorporated into DNA, causing chain termination. Importantly, cytarabine's activity is almost exclusively limited to hematologic malignancies, acute leukemias, especially AML, and lymphomas. It has virtually no activity against solid tumors. Because it's rapidly broken down, it's often given as a continuous infusion over several days. Gemcitabine, in contrast, is another deoxycytidine analog, but it has broad-spectrum activity against both solid tumors and hematologic malignancies. It inhibits DNA synthesis through multiple mechanisms. It's a key drug in pancreatic cancer, lung cancer, bladder cancer, breast cancer, and others. Its main toxicity is myelosuppression.
Interesting divergence there between cytarabine and gemcitabine. What's the last group of antimetabolites?
Finally, the purine antagonists. These interfere with the synthesis and metabolism of purines, adenine and guanine, which are essential DNAR building blocks. 6-mercaptopurine, 6-MP, and 6-thiaguanine, 6-DG, are key examples, primarily used in treating acute leukemias. They get converted into fraudulent nucleotides that inhibit purine synthesis pathways and get incorporated into dRNA. There's a critical drug interaction with 6-MP. It's partly broken down by an enzyme called xanthine oxidase. Allopurinol, a drug often given to cancer patients to prevent gout caused by tumor lysis, inhibits xanthine oxidase. So giving allopurinol with 6-MP leads to dangerously high 6-MP levels and severe toxicity. 6-MP dose must be significantly reduced if given with allopurinol. This interaction doesn't happen with 6-TG. Another genetic factor here is TPMT deficiency. The alpurine methyltransferase, TPMT, also metabolizes these drugs. Patients with low TPMT activity are at high risk for severe myelosuppression from standard doses. Testing for TPMT status is often done before starting these drugs. Fludarabine is another purine analog, mainly used for chronic lymphocytic leukemia, CLL, and low-grade lymphomas.
It interferes with DNA synthesis and repair and induces apoptosis. A major side effect is significant immunosuppression, increasing the risk of opportunistic infections, requiring prophylactic antibiotics. Cladribine is similar, highly effective in hairy cell leukemia and other low-grade lymphoid malignancies. It also causes myelosuppression and long-lasting immunosuppression.
Wow, that covers a lot of ground just within the antimetabolites. The genetic factors like DPD and TPMT really highlight the move towards personalized medicine. Okay, let's move on. What about drugs derived from natural sources?
Yes, the natural product cancer chemotherapy drugs are a really diverse and important group. Many of our most effective agents come from plants, microbes, or marine organisms. Let's start with the vinca alkaloids. These include vinblastine, vincristine, and vinorelbine. They are derived from the periwinkle plant, Vinca rosea. Their mechanism involves binding to tubulin, the protein subunit that makes up microtubules. Microtubules are essential components of the cell's cytoskeleton and, critically, form the mitotic spindle required for cell division, M phase. By inhibiting tubulin polymerization, the vinca alkaloids prevent the proper assembly of the mitotic spindle. This causes cells to arrest in metaphase, unable to complete division, which ultimately leads to cell death. So they are M phase specific. Vincristine is used in treating lymphomas, breast cancer, and germ cell cancer. Its main side effects are myelosuppression, nausea, vomiting, and alopecia. Vincristine is structurally very similar, but has a strikingly different clinical profile. It's a key drug in childhood all-induction therapy, other lymphomas, and pediatric solid tumors. Its major dose-limiting toxicity is neurotoxicity. It has a higher affinity for microtubules and nerve axons, leading to peripheral neuropathy, numbness, tingling, weakness, constipation due to autonomic nerve effects, and other neurological issues. Myelosuppression is usually much milder than with vinblastine. Vinorelbine is a semi-synthetic derivative used mainly for lung and breast cancer, with myelosuppression being its primary dose-limiting toxicity.
The neurotoxicity difference between vinblastine and vincristine is fascinating, given how similar they are. Okay, what other natural products target microtubules?
The other major class of microtubule inhibitors are the taxanes. This includes paclitaxel, docetaxel, and cabazitaxel. Paclitaxel was originally isolated from the bark of the Pacific yew tree, Taxus brevifolia. Docetaxel is semi-synthetic, derived from the European yew. Now, taxanes also target microtubules and are M-phase specific, but they work in the opposite way to vinca alkaloids. Instead of inhibiting assembly, they enhance tubulin polymerization and stabilize existing microtubules. They essentially freeze the microtubule structure, preventing the dynamic instability needed for spindle function and cell division. Mitosis is blocked, leading to cell death. Paclitaxel has incredibly broad activity against many solid tumors: ovarian, breast, lung, head and neck, esophageal, prostate, bladder. A real workhorse drug. A major issue historically was hypersensitivity reactions, HSRs, due to the solvent used to dissolve it, cremoform. Premedication with steroids and antihistamines is standard to prevent this. A newer formulation, nab-paclitaxel, albumin-bound, avoids the need for cremophor and doesn't cause HSRs. It also seems to cause less myelosuppression. Docetaxel is similar in activity and mechanism, perhaps slightly more potent. Also widely used in breast, lung, prostate, gastric, head, and neck cancers. Cabazitaxel is interesting because it's a poor substrate for the P-glycoprotein efflux pump we discussed earlier. This means it might retain activity in tumors that have become resistant to paclitaxel or docetaxel due to P-glycoprotein overexpression. It's approved for prostate cancer after docetaxel failure. Other antimicrotubule drugs include ixabepilone and isapothilone, and eribulin, the halocondrin B analog, both used primarily in metastatic breast cancer and notable for activity in drug-resistant settings.
So two major classes hitting microtubules, but in opposite ways. Fascinating. What about drugs targeting the DNA machinery itself, but differently from alkylators platinums?
Yes. That brings us to the topoisomerase inhibitors. Topoisomerases are essential enzymes that manage the complex topology of DNA cutting, untangling, and religating DNA strands to allow processes like replication and transcription to occur without the DNA getting hopelessly tangled. There are two main types, topo-As and topoisomer, and drugs that target each. First, the epiphytophyllotoxins like etoposide. This is derived from the mayampa root. Etoposide specifically inhibits topoisomerase 2. It doesn't just block the enzyme, it traps it in a complex with DNA after it has made a double-strand cut, but before it has religated the strands. This leads to permanent double-strand breaks, DNA damage, and inhibition of DNA synthesis. Etoposide is a key drug in treating germ cell cancers, small cell lung cancer, and lymphomas.
Okay, so etoposide targets topo-2, causing double-strand breaks. What about topo-I inhibitors?
Those are the camptothecins. This class includes irinotecan and topotecan. They are derived from the Camptotheca acuminata tree. They specifically inhibit topoisomerase I, which is responsible for making single-strand breaks to relieve torsional stress in DNA. Like etoposide, they trap the enzyme DNA complex after the cut but before religation, leading to lethal single-strand breaks that convert to double-strand breaks when the replication machinery hits them. Irinotecan is a prodrug, converted in the liver to its highly active metabolite, SN38. It's a cornerstone treatment for colorectal cancer, often used in the FOLFIRI regimen. Its most notorious side effect is severe, potentially life-threatening diarrhea, which can occur both early, cholinergic, treatable with atropine, and late, more problematic. Topotecan is used mainly for ovarian cancer and small cell lung cancer. We also now have antibody-drug conjugates using camptothecin derivatives like sacituzumab govitecan targeting TROP2 and trastuzumab deruxtecan targeting HER2, delivering a potent topo-I inhibitor directly to the tumor cell. Deruxtecan, the payload in the latter, is exceptionally potent.
These antibody-drug conjugates sound like a really smart way to deliver these potent toxins. Okay, what's the last major group of natural products?
The anti-tumor antibiotics. This is a diverse group, mostly isolated from Streptomyces bacteria. They generally work by binding to DNA, often through intercalation, slipping between the DNA base pairs, which blocks DNA and RNA synthesis and can cause strand breaks. The most important subgroup here are the anthracyclines. This includes doxorubicin, daunorubicin, idarubicin, epirubicin, and the related compound mitoxantrone. Anthracyclines are among the most widely used and effective cytotoxic drugs we have. They have multiple mechanisms. They inhibit topoisomerase 2, like etoposide. They intercalate into DNA-blocking synthesis, they bind to cell membranes, and crucially, they generate free radicals. This free radical generation, particularly via interaction with iron, is thought to be the primary cause of their major dose-limiting toxicity, cardiotoxicity. Anthracyclines can cause an acute form, arrhythmias, usually transient, and a chronic dose-dependent dilated cardiomyopathy leading to heart failure. This risk limits the total cumulative dose a patient can receive over their lifetime. Doxorubicin, adriamycin, is one of the most important single agents, active against a huge range of cancers.
Breast, lymphoma, sarcomas, lung, ovarian, bladder, stomach.
Mm-hmm.
The list goes on. It's often a key component of combination regimens. Daunorubicin and idarubicin are mainly used in treating acute leukemias. Epirubicin is used in breast and gastric cancers. Mitoxantrone is structurally related and used in prostate cancer, leukemia, and breast cancer. It's generally considered less cardiotoxic than doxorubicin, but the risk isn't zero.
That cardiotoxicity is a really serious concern. Are there other important anti-tumor antibiotics?
Yes, a couple more to mention. Mitomycin C is interesting. It's an antibiotic that, after being activated inside the cell, especially in low oxygen conditions, acts as an alkylating agent, cross-linking DNA. Because it's preferentially activated in hypoxic, low oxygen environments, which are common inside solid tumors, mitomycin is particularly good at targeting these resistant hypoxic tumor cells. It's often combined with radiation therapy, especially for anal cancer. It can also be instilled directly into the bladder to treat superficial bladder cancer with minimal systemic absorption. A rare but serious side effect is hemolytic uremic syndrome, HUS. Finally, bleomycin. This is a small peptide that binds to DNA and in the presence of iron and oxygen generates free radicals that cause both single and double-strand DNA breaks. It's cell cycle specific, causing cells to accumulate in the G2 phase. Bleomycin is used in treating lymphomas, especially Hodgkin, testicular cancer, and squamous cell cancers. A major advantage is that it causes very little myelosuppression, making it easy to combine with other bone marrow toxic drugs. However, its major dose-limiting toxicity is pulmonary toxicity. It can cause lung inflammation, pneumonitis, that can progress to fibrosis, which can be fatal. The risk increases with age, higher cumulative doses, and pre-existing lung disease.
Minimal myelosuppression, but potential lung toxicity. Another example of those tricky trade-offs. Okay, we've covered the traditional arsenal pretty thoroughly. Now let's really dive into the newer era, the targeted therapies and immunotherapies. This is where things get really interesting, leveraging our deeper understanding of cancer biology.
Absolutely. This is where we see the shift from broader cytotoxic effects to hitting specific molecular targets driving the cancer or harnessing the patient's own immune system. It's a much more precise approach. Let's start with the landmark example, BCR-ABL tyrosine kinase inhibitors, TKIs. These truly revolutionize the treatment of chronic myelogenous leukemia, CML. CML is driven by a specific genetic abnormality, the Philadelphia chromosome, creating a fusion protein called BCR-ABL. This BCR-ABL protein is a tyrosine kinase that's permanently switched on, constantly signaling leukemia cells to grow and divide. Imatinib was the first TKI specifically designed to inhibit the BCR-ABL kinase. It binds to the protein and blocks its activity, shutting down the primary driver of the disease. The impact was staggering. It turned CML from a typically fatal disease into a manageable chronic condition for most patients, often controlled with just a daily pill. Imatinib is now standard first-line therapy. Of course, resistance can develop, often through mutations in the BCR-ABL kinase itself. This led to the development of second-generation TKIs like dasatinib and nilotinib, which can overcome many imatinib resistance mutations. Bosutinib and ponatinib are used for even more resistant cases. Ponatinib is particularly notable because it's active against the notorious T3-CFDI mutation, a gatekeeper mutation that confers resistance to most other TKIs. And the newest kid on the block is asciminib, which works differently. It binds to a different site on BCR-ABL, an allosteric site, stabilizing an inactive form. This offers another way to combat resistance. A key point for all these TKIs is that they are metabolized by liver enzymes, CYP3A4, so managing potential drug interactions is crucial. Things like grapefruit juice can interfere with metabolism and increase toxicity.
The CML story is a fantastic example of successful targeted therapy. What other targeted pathways are exploited?
Another important target, particularly in multiple myeloma, is the proteasome. The 26S proteasome is like the cell's garbage disposal, breaking down unneeded or damaged proteins. Proteasome inhibitors, like bortezomib, block this garbage disposal. In multiple myeloma cells, this leads to a buildup of toxic proteins and, crucially, interferes with the NF-key signaling pathway, which is a major survival pathway for these cells. Blocking the proteasome essentially disrupts key survival signals. Bortezomib was the first proteasome inhibitor approved and has become a cornerstone of myeloma treatment, used both upfront and for relapse disease. It can be given intravenously or subcutaneously. A main side effect is peripheral neuropathy. Carfilzomib and the oral agent ixazomib are newer proteasome inhibitors, offering alternatives, especially in cases of bortezomib resistance.
Okay, targeting protein degradation. What about manipulating the immune system or other signaling pathways?
Yes, the immunomodulatory analogs, IMADs, are another key class, also central to treating multiple myeloma. This group includes thalidomide, lenalidomide, and pomalidomide. Thalidomide, infamous for its history, was found to have significant activity in myeloma. Its exact mechanisms are complex, involving effects on the tumor microenvironment, angiogenesis inhibition, and direct effects on myeloma cells, including enhancing immune cell function against the tumor. Lenalidomide is a more potent analog with a generally better side effect profile, especially less neurotoxicity, and is now widely used in first-line and subsequent myeloma therapies, often combined with dexamethasone or proteasome inhibitors. Pomalidomide is used for patients whose disease has become resistant to both lenalidomide and bortezomib.
Thalidomide's comeback story is remarkable. Let's move to growth factor receptors. These seem like prime targets.
They absolutely are. Many cancers hijack normal growth factor signaling pathways to drive their proliferation. So inhibiting these pathways is a major strategy. Let's look at the epidermal growth factor receptor, EGFR, pathway first. EGFR is overexpressed in many solid tumors, colorectal, lung, head and neck, pancreatic. Its activation triggers downstream signals promoting growth, invasion, metastasis, and even resistance to chemotherapy and radiation. We have two main ways to block EGFR. 1. Monoclonal antibodies. These target the outside part of the receptor. Cetuximab and panitumumab are examples used in colorectal cancer. They bind to EGFR and prevent the growth factor from activating it. A critical point. These antibodies only work in patients whose tumors have wild-type RAS genes. If RAS, kreosoranarose, is mutated downstream, blocking EGFR upstream won't help because the growth signal is already locked on further down the pathway. This is a key example of biomarker-driven therapy. Cetuximab is also used with radiation for head and neck cancer. Nestumumab is another anti-EGFR antibody used specifically for squamous non-small cell lung cancer.
Common side effects include an acne-like skin rash and sometimes infusion reactions. 2. Small molecule tyrosine kinase inhibitors, TKIs. These target the inside part of the receptor, the kinase domain, blocking its signaling activity. Erlotinib, alphatinib, and osimertinib are key examples used primarily in non-small cell lung cancer, NSCLC. Their effectiveness is highly dependent on the presence of specific activating mutations in the EGFR gene, like exon 19 deletions or the LA508R mutation. Patients with these mutations often have dramatic responses to these TKIs. Osimertinib is particularly important as it's effective against the T790M resistance mutation that often develops after treatment with earlier EGFR TKIs, and is now also used first-line. Side effects often include rash and diarrhea.
The importance of testing for those RAS and EGFR mutations seems paramount for selecting the right patients. What about the HER2 receptor? That's a big one in breast cancer, right?
Huge. The ARIA or ERI2 growth factor receptor is overexpressed in about 20-25% of breast cancers and also in some gastric and esophageal cancers. ERI2 overexpression drives aggressive tumor growth. Trastuzumab was the first major anti-ERI2 therapy, a monoclonal antibody that binds to the outside of the ERI2 receptor. Adding trastuzumab to chemotherapy for HER2-positive breast cancer, both in the adjuvant and metastatic settings, has dramatically improved outcomes. Its main toxicity concern is potential cardiotoxicity, decreased heart function. Pertuzumab is another antibody that binds to a different part of HER2, preventing it from pairing up with other HER2 receptors. It's often used in combination with trastuzumab and chemotherapy. Then we have the antibody-drug conjugates, ADCs, which are revolutionizing HER2-positive treatment. Trastuzumab emtansine, TDM1, links trastuzumab to a potent microtubule inhibitor, DM1. Trastuzumab deruxtecan, TDXT, links trastuzumab to a highly potent topoisomerase I inhibitor, deruxtecan. These ADCs deliver a massive chemotherapy payload directly to the ERU2-expressing cells, offering remarkable efficacy even in patients resistant to other HER2 therapies.
TDXT is showing activity even in tumors with low levels of HER2 expression, broadening its potential use. There are also small molecule HER2 TKIs, like lapatinib, neratinib, and tucatinib. These block the internal kinase signaling of HER2 and sometimes EGFR2. They offer oral options and can be effective after progression on antibody therapies. Tucatinib is notable for its ability to effectively treat brain metastases in HER2-positive breast cancer.
Those ADCs sound incredibly promising. What about targeting the tumor's blood supply? You mentioned VEGF inhibitors earlier.
Right. Targeting angiogenesis, the formation of new blood vessels that tumors need to grow and spread, is another key strategy. Vascular endothelial growth factor, VEGF, is a major driver of this process. Again, we have different approaches. 1. Targeting the VEGF ligand. Bevacizumab is a monoclonal antibody that binds directly to the VEGF-A protein itself, preventing it from activating its receptors on blood vessel cells. It's approved for use in combination with chemotherapy for several cancers, including colorectal, lung, kidney, cervical, and ovarian cancer. It generally doesn't worsen chemo side effects like myelosuppression, but has its own unique risks, including hypertension, bleeding, blood clots, wound healing problems, and rarely, bowel perforation. Zibafilibrcept is a VEGF trap, a fusion protein that also binds VEGF-A and related factors, acting as a decoy receptor. 2. Targeting the VEGF receptor. Ramucirumab is a monoclonal antibody that directly targets VEGF receptor 2, VEGFR2, the main receptor mediating VEGF's angiogenic effects. It's approved for gastric, lung, colorectal, and liver cancers. 3. Small molecule multikinase inhibitors. Several oral small molecule drugs inhibit the tyrosine kinase activity of VEGF receptors, as well as other receptor tyrosine kinases involved in tumor growth and angiogenesis, like PDGFR, BRISKIT, RAF. Examples include sorafenib and sunitinib, used in kidney and liver cancer, GAS, and pazopanib, used in kidney cancer. These multi-targeted agents block multiple signaling pathways simultaneously. Common side effects include hypertension, fatigue, diarrhea, skin rash, and hand-foot syndrome. Like the BCR-ABL TKIs, managing drug interactions due to liver metabolism, CYP3A4, is important.
It's incredible how many specific targets have been identified and how drugs have been designed to hit them. Okay, we have this vast knowledge of mechanisms, drugs, classes, and targeted approaches. Now let's see how this plays out in practice. So what does this all mean when treating specific types of cancer? Can you walk us through some key examples?
Definitely. Applying this knowledge is where it all comes together. Let's start with leukemias. For acute leukemia, treatment differs significantly between childhood and adult forms. Childhood acute lymphoblastic leukemia, ALL, is the most common childhood cancer and thankfully has a relatively good prognosis now. Multi-agent chemotherapy regimens using drugs like vincristine, prednisone, methotrexate, and 6-mercaptopurine achieve high remission rates, 90%.
A critical part of treatment is prophylactic intrathecal methotrexate therapy. This means injecting chemo directly into the spinal fluid to prevent leukemia cells from hiding out in the central nervous system, brain and spinal cord, which used to be a major site of relapse. For relapsed B-cell a HAR T-cell therapy like T-Segen Listlo-cell, which engineers the patient's T-cells to attack leukemia cells, has been a major advance. Adult acute myelogenous leukemia, AML, is tougher. The cornerstone of induction therapy is cytarabine, usually combined with an anthracycline like daunorubicin or daunorubicin. This achieves remission in about 70% of patients, but consolidation therapy, more chemo after remission, is essential for long-term cure.
And chronic myelogenous leukemia, CML. You mentioned the TKIs earlier.
Right, CML is the poster child for targeted therapy. Driven by the BCR-ABL fusion protein resulting from the Philadelphia chromosome translocation, it's treated first-line with TKIs like imatinib, dasatinib, or nelatinib. These drugs target the BCR-ABL directly, leading to deep and durable remissions for most patients, transforming the disease course. For resistant cases, ponatinib or asciminib offer further options.
That CML story really is remarkable. What about the lymphomas, Hodgkin and non-Hodgkin?
Hodgkin lymphoma has also seen dramatic improvements. For early-stage disease, stage 30A, the standard has shifted from extensive radiation alone to combined modality therapy. Shorter courses of combination chemotherapy followed by radiation only to the involved areas. This maintains high cure rates while reducing long-term side effects of radiation, like secondary cancers and heart disease. For advanced stage Hodgkin, stage 3, the combination regimen ABVD, doxorubicin, bleomycin, vinblastine, dacarbazine, is the standard, offering high cure rates. Around 80% achieve complete remission, maybe 60% cured long-term, and is less toxic than the older MOPP regimen, especially regarding fertility. For refractory disease, immune checkpoint inhibitors like nivolumab and pembrolizumab, targeting the PD-1 pathway, have shown significant activity. Non-Hodgkin lymphoma, NHL, is a much more diverse group of diseases. For aggressive types like diffuse large B-cell lymphoma, DLBCL, the standard initial therapy is RCO-TP, rituximab plus TCHO chemotherapy. Rituximab is a monoclonal antibody targeting CD20, a protein on B-cells, and adding to CHB significantly improves survival rates.
For relapsed refractory DLBCL, Custer RT cell therapies targeting CD19, like disazoleclucel and ex-capucine-silulucel, are now approved and can induce durable remissions. In contrast, low-grade nodular follicular lymphomas are often slow-growing, but usually widespread at diagnosis and considered incurable with current chemo. Interestingly, for asymptomatic patients, immediate treatment doesn't improve overall survival compared to a watchful waiting approach, starting therapy only when symptoms develop. Treatment is generally palliative.
Watchful waiting. That seems counterintuitive for cancer. Fascinating. How about multiple myeloma? You mentioned the proteasome inhibitors and IMEDs.
Yes, multiple myeloma, a cancer of plasma cells in the bone marrow, has undergone a therapeutic revolution in the past 15-20 years. Historically, treatment was mainly the alkylating agent melphalan plus prednisone. Now, the backbone of therapy, especially first line, involves combinations of proteasome inhibitors like bortezomib, carfilzomib, ixazomib, and immunomodulatory analogs, IMEDs, like guanylomide, pomalidomide, usually along with dexamethasone. These triplet or doublet regimens target key survival pathways for myeloma cells. Other important agents include monoclonal antibodies like daratumumab, targeting CD38 on myeloma cells, and for heavily pretreated patients, a CAR T-cell therapy targeting BCMA, B-cell maturation antigen, like adicabtagene-viclucel, IDCEL, is showing significant promise, although it comes with risks like cytokine release syndrome, CRS, and neurotoxicity.
Okay, let's shift to solid tumors. Breast cancer is so common. How has chemotherapy impacted its treatment?
Breast cancer management has evolved dramatically, particularly with early detection and the use of adjuvant therapy. For stage 2 disease, where cancer has spread to lymph nodes, post-operative adjuvant chemotherapy is standard. Regimens like CMF, cyclophosphamide, methotrexate, fluorouracil, or AC, doxorubicin, cyclophosphamide, often followed by a taxane, significantly reduce the risk of recurrence and improve overall survival, especially in premenopausal women. For the 20-25% of breast cancers that are HER2 positive, adding trastuzumab and potentially pertuzumab to adjuvant chemotherapy has been a massive leap forward, significantly improving outcomes. Extended adjuvant therapy with neratinib may be considered after trastuzumab. Hormonal manipulation is crucial for hormone receptor positive, ERPR positive breast cancer. Tamoxifen, an antiestrogen, was the standard for years, typically given for 5 years post-surgery. Now, aromatase inhibitors, like anastrozole, letrozole, which block estrogen production in postmenopausal women, are often used either instead of or sequentially after tamoxifen, often for a total of 5–10 years of endocrine therapy. For stage 3 and stage 4 advanced metastatic breast cancer, treatment is generally palliative, aiming to control the disease and maintain quality of life. Choices depend on hormone receptor status, HER2 status, and prior treatments. For hormone receptor-positive disease, endocrine therapies, aromatase inhibitors, fulvestrant, are often used first, potentially combined with CDK46 inhibitors, palbociclib, ribociclib, abemaciclib, which target cell cycle progression and have significantly improved progression-free survival. For HER2-positive metastatic disease, HER2-targeted therapies are the cornerstone. Trastuzumab, pertuzumab, and increasingly, the highly effective ADCs like TDM1 and TDXD. Small molecule TKIs like tucatinib also play a role, especially for brain metastases. For triple-negative breast cancer, negative for ER, PR, and HER2, chemotherapy remains the mainstay, although the ADC, sacituzumab, govitecan, and immunotherapy, like pembrolizumab combined with chemo in some settings, are providing new options. Combination chemotherapy regimens are often used, with anthracyclines and taxanes being key agents. While response rates can be high initially, remissions in the metastatic setting are often not durable.
The subtyping of breast cancer, HR status, HER2 status, clearly dictates the strategy. What about prostate cancer? You mentioned hormonal therapy earlier.
Yes, prostate cancer is highly dependent on androgens, like testosterone, for growth, making hormonal therapy a cornerstone. For metastatic disease, the initial approach is androgen deprivation therapy, ADT, eliminating testosterone production by the testes. This can be done surgically, orchiectomy, or, more commonly now, chemically using LHRH agonists like leuprolide, goserelin, or antagonists. Sometimes an anti-androgen, like bicalutamide and enzalutamide, is added initially. Newer, more potent hormonal agents like abiraterone inhibits androgen synthesis, and enzalutamide, potent AR inhibitors, are now used earlier, even in castration-sensitive metastatic disease, and also when the disease becomes castration-resistant, CRPC. ADT usually works well initially, controlling symptoms and lowering PSA levels for maybe a couple of years, but eventually the cancer adapts and progresses despite low testosterone levels, CRPC. For CRPC, options include switching hormonal agents or starting chemotherapy. Docetaxel-based chemotherapy combined with prednisone was the first regimen shown to improve survival in CRPC. It remains a standard. Cabazitaxel is an option after docetaxel. Metaxantrone is sometimes used for palliation of bone pain. The Sipuleucel T vaccine is an immunotherapy option for minimally symptomatic CRPC, using the patient's own dendritic cells activated against a prostate cancer antigen. Radium-223, a bone-targeting radiopseudo, is used for CRPC with bone metastases. PRP inhibitors like olaparib are approved for CRPC with specific DNA repair gene mutations like BRCA.
Lots of options now, even for advanced prostate cancer. Let's turn to gastrointestinal cancers. Colorectal cancer is a big one.
Colorectal cancer, CRC, is indeed very common. Treatment depends heavily on stage. For stage 3 and high-risk stage 2 colon cancer, adjuvant chemotherapy after surgery is standard. Oxalitin-based regimens like Eflafox, 5-FU, leucovorin, oxaliplatin, or Kepox, camptothecin, oxaliplatin, given for 3–6 months significantly reduce recurrence risk and improve survival. The duration, 3 versus 6 months, depends on risk factors. For metastatic CRC, mCRC, treatment has advanced significantly. The backbone is usually of fluoropyrimidine, 5-FU, or capecitabine, combined with either oxaliplatin, Eflafox, or irinotecan, FOLFIRI. To these cytotoxic backbones, we often add biologic agents. If the tumor has wild-type RAS genes, anti-EGFR antibodies like cetuximab or panitumumab can be added, usually not combined with oxaliplatin initially due to toxicity, often used with FOLFIRI or single agents later. Alternatively, the anti-VEGF antibody bevacizumab can be added to either Eflafox or FOLFIRI, irrespective of RAS status. Other anti-angiogenic agents like zivaflibercept or ramucirumab are options in later lines. The goal is often a continuum of care, trying to expose patients to all active agents over the course of their disease.
For patients whose tumors are MSI high, microsatellite instability high, which occurs in about 15% of CRC, more common in earlier stages, less in metastatic, immune checkpoint inhibitors like pembrolizumab or nivolumab, ipilimumab, are highly effective and approved, often used up front. In later lines for chemorefractory mCRC, the oral agents regorafenib, a multikinase inhibitor, and TAS-102, a novel fluoropyrimidine combo, offer modest benefits. Median overall survival for mCRC has now reached around 30 months or more with optimal sequencing of therapies.
The importance of molecular testing, RAS, MSI, and CRC is really clear. What about liver cancer?
Hepatocellular cancer, HCC, primary liver cancer, is challenging, often arising in the context of cirrhosis. It's historically been relatively resistant to traditional chemotherapy. For unresectable advanced HCC, sorafenib, a multikinase inhibitor, was the standard first-line systemic therapy for many years. Lenvatinib is another TKI option. However, the current preferred first-line standard for patients who can tolerate it is the combination of the immune checkpoint inhibitor anezolizumab plus the anti-VEGF antibody bevacizumab. This combination showed superior survival compared to sorafenib. In the second-line setting, after progression on first-line therapy, options include other TKIs like regorafenib or cabozantinib, immune checkpoint inhibitors like pembrolizumab or nivolumab, or the anti-VEGFR2 antibody ramucirumab if the alpha-fetoprotein level is high.
Immunotherapy moving to first line in HCC is a big shift. Okay, lung cancer, another major one with different subtypes.
Right. Lung cancer is broadly split into non-small cell lung cancer, NSCLC, about 80%, includes adenocarcinoma, squamous cell, large cell, and small cell lung cancer, SCLC, about 20%. For NSCLC, treatment is highly dependent on stage and molecular characteristics. Early stage disease can be cured with surgery, often followed by adjuvant platinum-based chemotherapy for stages IBI there. Unfortunately, most NSCLC is diagnosed at an advanced stage. Here, molecular testing is absolutely essential. If the tumor has an EGFR sensitizing mutation, first-line therapy is an EGFR TKI, like osimertinib. If the tumor has an ALK rearrangement, first-line therapy is an ALK inhibitor, like alectinib or others. There are other targetable mutations too: ROS1, BRAFA, V600E, MET exon 14, RET, and TRK. Identifying these allows for targeted therapy up front. For patients without these specific driver mutations, immunotherapy is now central to first-line treatment. Patients with high PD-L1 expression might receive pembrolizumab alone. Most others receive platinum-based doublet chemotherapy, Vucrexy, carboplatin Pimitrex for non-squamous, carboplatin paclitaxel for squamous, combined with pembrolizumab.
The anti-VEGF antibody bevacizumab can be added to chemo for non-squamous histology. Small cell lung cancer, SCLC, is much more aggressive. It's usually very sensitive to initial platinum-based chemotherapy, often cisplatin etoposide, but resistance develops quickly and relapse is common. For extensive-stage SCLC, the current first-line standard is chemotherapy combined with the anti-PD-L1 inhibitor editsilizumab. For relapsed SCLC, options include tepotecin or lurbinectedin.
The molecular stratification in NSCLC is incredible. Okay, a few more key cancers. Ovarian cancer.
Ovarian cancer often presents at an advanced stage after spreading within the peritoneal cavity. Standard treatment involves surgery followed by combination chemotherapy, typically carboplatin plus paclitaxel. A major advance has been the introduction of PRP inhibitors like olaparib, niraparib, rucaparib. These drugs are particularly effective in tumors with BRCA mutations, germline or somatic, or other defects in homologous recombination DNA repair, HRD. They are used both as treatment for recurrent disease and, importantly, as maintenance therapy after response to platinum-based chemotherapy, significantly delaying recurrence.
Testicular cancer. You mentioned cisplatin was curative there.
Yes, testicular cancer is one of the great success stories of chemotherapy. Platinum-based combination chemotherapy, usually the PEP regimen, cisplatin, etoposide, bleomycin, cures the vast majority of men, even those with advanced metastatic disease. For good-risk patients, 3 cycles of PE or 4 cycles of EP etoposide are standard. High-risk disease might involve more intensive regimens.
And malignant melanoma. Historically tough, but now with immunotherapy.
Malignant melanoma treatment has been completely transformed. While localized disease is cured surgically, metastatic melanoma was once very difficult to treat with traditional chemo, like dacarbazine. The revolution came with immunotherapy and targeted therapy. Immune checkpoint inhibitors targeting CTLA-4, ipilimumab, and PD-1, nivolumab, pembrolizumab, have dramatically improved survival, offering durable responses and potential cures for a subset of patients with metastatic disease. Combination immunotherapy, nivolumab plus ipilimumab, is even more effective but also more toxic. These agents are also now used in the adjuvant setting for high-risk resected melanoma to reduce recurrence risk. About 50% of melanomas have BRAF mutations, most commonly V600E. Highly effective oral BRAF inhibitors, vemurafenib, dirafinib, and corafinib, combined with MEK inhibitors, trametinib, cobimetinib, and binimetinib, provide rapid and high response rates in these patients. This combination is standard first-line therapy for BRAF mutant metastatic melanoma and also used in the adjuvant setting.
Finally, brain cancer always seems particularly challenging.
Brain cancer, particularly malignant gliomas like glioblastoma multiforme, GBM, remains very challenging. Chemotherapy efficacy is often limited by the blood-brain barrier. Historically, the nitrosoureas, carmazine, lomazine, were most used due to their ability to cross the BB. Currently, the alkylating agent temozolomide, given concurrently with and after radiation therapy, is the standard of care for newly diagnosed GBM. It provides a modest survival benefit. Bevacizumab, anti-VEGF, is approved for recurrent GBM, providing some symptom control and delaying progression, but doesn't clearly improve overall survival. Oligodendrogliomas are somewhat more chemosensitive, often responding to regimens like PCV, procarbazine, lomustine, vincristine. Research continues actively in this difficult area.
That covers an immense amount of ground on specific cancers. But before we wrap up, we need to address that darker side you mentioned earlier, the risk of secondary malignancies from the treatment itself. This raises an important question. How significant is this risk?
It's a very important question, especially as more patients survive their primary cancer long term. Yes, certain chemotherapy drugs, particularly alkylating agents and epipodophyllotoxins, like etoposide, are known to increase the risk of developing a second cancer later in life. The most common secondary malignancy associated with these drugs is acute myelogenous leukemia, AML, often referred to as therapy-related AML or TAML. The risk isn't trivial. For example, in historical cohorts of Hodgkin lymphoma patients treated with regimens like MOPP plus radiation, the risk of developing AML could be as high as 15% over time. It's also seen after treatment for myeloma, ovarian cancer, and breast cancer involving alkylating agents like melphalan. This increased risk typically emerges a few years after chemotherapy, often peaking around 5 to 9 years post-treatment. Therapy-related AML is often associated with specific chromosomal abnormalities and can be difficult to treat.
AML is the main one, but are there others?
Yes, other secondary cancers like non-Hodgkin lymphoma and bladder cancer, the latter particularly linked to cyclophosphamide due to bladder irritation by its metabolite acrolein, have also been associated with certain chemo regimens. Etoposide is linked to AML subtypes with a specific 11q23 chromosome translocation. More recently, there have been reports of myelodysplastic syndrome, MDS, and secondary AML associated with the use of PRP inhibitors. It's a bit complex because most patients receiving PRP inhibitors have also had prior platinum chemotherapy, which is itself a risk factor. The risk seems higher in those with BRCA mutations. And as mentioned earlier, BRAF inhibitors used for melanoma are associated with an increased risk of secondary squamous cell skin cancers. It really highlights that chemotherapy is a powerful tool with potential long-term consequences. It's a constant focus in drug development to find therapies that are not only more effective, but also less likely to cause these devastating late effects.
Absolutely, a critical consideration. Okay, this has been an incredibly detailed journey. Let's bring it all home by revisiting that initial case study, the 55-year-old man with colon cancer, and see how all this knowledge applies.
Great idea. So let's recap. 55-year-old man, symptoms of fatigue, weight loss, anemia. Colonoscopy finds a tumor in the ascending colon. Biopsy confirms CRC. Surgery reveals high-risk stage 3 disease with 5 out of 12 lymph nodes positive. He recovers well from surgery. First, prognosis. With high-risk stage 3 colon cancer, meaning multiple positive nodes, the 5-year survival rate after surgery alone is roughly in the 25–30% range. That's a high risk of recurrence. Therefore, given that he's recovered well and has no other major health issues, he is definitely an appropriate candidate for adjuvant chemotherapy. We typically start this 4 to 6 weeks after surgery. The goal is to kill any micrometastases, reduce his recurrence risk, and improve his chance of long-term survival.
And what specific adjuvant chemo would be recommended and for how long?
The standard is an oxaliplatin-based regimen, either FOLFOX, 4B5-fluoroquivorn plus oxaliplatin, or CAPOX, oral capecitabine plus oxaliplatin. Historically, 6 months was standard. Recent studies, the IDEA collaboration, show that for some stage 3 patients, lower risk, fewer nodes, 3 months might be sufficient, especially with CAPOX offering less toxicity, particularly neuropathy from oxaliplatin. However, for this patient with high-risk disease, 5 positive nodes, the standard recommendation would still be for a full 6 months of FOLFOX or CAPOX to maximize the benefit, despite the increased risk of cumulative toxicity like neuropathy. It's a risk-benefit discussion tailored to the individual.
Okay, so he starts FOLFOX, but then the case is 1 week later, he develops severe toxicity. Myelosuppression, diarrhea, altered mental status. What's the most likely cause?
Given that triad of toxicities appearing acutely after the first cycle of a 5-FU-based regimen, the most likely explanation is DPD deficiency, a deficiency in the dihydropyrimidine dehydrogenase enzyme that metabolizes 5-FU. As we discussed, this pharmacogenetic syndrome affects a significant minority of the population. Up to 10% may have partial deficiency. It prevents normal breakdown of 5-FU, leading to massively increased drug exposure and severe toxicity affecting the bone marrow, GI tract, and nervous system. He's presenting with the classic triad, although not everyone with DPD deficiency gets all three.
So should he undergo genetic testing now to confirm DPD deficiency?
This is where current guidelines are nuanced. Routine genetic testing for DPD gene mutations before starting 5-FU is not currently standard practice in North America, although it's done more often in some European countries. Why not?
Well, firstly, genetic testing identifies mutations, but not all mutations necessarily lead to reduced enzyme function. And secondly, nearly half of patients who experience severe 5-FU toxicity don't have one of the known common DPDG mutations that are typically tested for. So while testing can be done, especially now that he's experienced toxicity, a potentially more practical approach in this situation might be therapeutic drug monitoring, actually measuring the levels of 5-SU in his blood. This can directly assess his ability to clear the drug and help guide dose adjustments if treatment with the fluoropyrimidine is to be continued, or guide the physician to switch to a non-fluoropyrimidine regimen altogether.
That's a fantastic practical application of everything we've discussed. What a journey through the world of cancer chemotherapy. From the fundamental biology of cancer, the mechanisms of action for dozens of drugs, the strategies of combination and dose intensity, the challenge of resistance, the specifics of treating different cancers, and even the long-term risks. It's incredibly complex.
It truly is. And understanding these mechanisms, the why behind the treatments, is absolutely crucial if you want to grasp not just current practice, but also where the field is heading. New targeting agents, new immunotherapies, new ways of combining treatments, they all build on this foundational knowledge.
Knowing these details really does help make sense of the news, the research breakthroughs, even policy discussions around cancer care. It moves beyond just names of drugs to understanding the intricate biological battle being waged.
Exactly. It allows you to appreciate the science, the challenges, and the remarkable progress that continues to be made.
So, as we wrap up this deep dive, what does this all mean for you, our listeners? We leave you with this thought. Considering the incredible adaptability of cancer cells, their knack for developing resistance through mechanisms like genetic instability and efflux pumps, what might be the next frontier? Could it be moving beyond just developing new drugs to attack the cancer, towards entirely novel strategies aimed at predicting, preventing, or even reversing resistance itself, fundamentally changing the dynamics of this ongoing arms race? Something to ponder. Thank you for joining us for another in-depth exploration here on The Deep Dive. We hope this journey through cancer chemotherapy leaves you feeling more informed and perhaps even a bit more hopeful about the power of science in tackling this immense challenge.